Oh. So good morning and welcome to today's cardiovascular webinar, jointly sponsored by the Society for Biomaterials and the International Society for Applied Cardiovascular Biology. I'm Dan Lemire, the Executive Director of the Society for Biomaterials. Before we get started, if you have any questions, please type them into the questions pane. We'll do our best to address them with each speaker at the end of the presentations. A recording of this webinar will be available on the SFB website in the next few days. Nan Wang was to have joined us as our moderator today, but unfortunately not able to be here at the moment. So if I may, I'll assume the honor of introducing our first speaker, Nicholas Leroux. Nicholas holds a bachelor's degree in biochemistry and a master's degree in immunology and microbiology, and a PhD in molecular and cell biology from Laval University in Quebec City, Canada. He completed his training as a postdoc fellow of the American Heart Association at the Bioengineering Department at the University of California, San Diego. In 2000, he co-founded Cytograph Tissue Engineering Incorporated in San Francisco, where he held the position as Chief Scientific Officer for 15 years. He joined INSERM, the French Institute of Health and Medical Research, in 2015 as a research director at the Laboratoire des Bioengineering Tissulaires, BioTIS, at the University of Bordeaux. Dr. Leroux has raised over $20 million in private funding and won 7 NIH grants. He's the recipient of a chair from the Excellence Initiative of the University of Bordeaux, and as well as an A&R grant. He was recently awarded an ERC Advanced grant. Congratulations, Dr. Leroux. And with that, I will make you the presenter today. And you should be able to share your screen now.
Yes. Is that looking good?
Looks good, thank you.
Like this?
Yeah, I'm seeing your PowerPoint in its application. So not the slideshow, but the PowerPoint application, actually.
Oh, you're not seeing the slideshow?
No. So in the sharing pane, just choose the window of the application that you want to share. There you go.
Perfect. Okay, well, thank you very much, Dan. Let me start a little timer on my side so I'm not going too much over my time. Yes, thank you for the very nice introduction. Thank you for the invitation. It's my pleasure to be here. Good morning, good afternoon, good evening, depending on where you are. So today I'm going to talk to you about how I use cell-assembled extracellular matrix to tissue engineer a completely biological and human vascular graft. So we can produce, or we can have cells produce cell-assembled matrix, or CAM for short, but I like to work mostly with fibroblasts from the skin, human skin fibroblasts. These are completely normal cells that we can get from adults or even elderly adults, and also from patients that suffer from various diseases. We have shown that we can mass produce these sheets in a 10 by 18 centimeter format that's using T225s. And these sheets that have no exogenous scaffolding, that are not chemically cross-linked or denatured in any way, are mechanically quite strong. You can see here a sheet that supports a 500-gram weight of metal. And it's very strong because of its collagen network. The architecture of the collagen is very close to that we find in normal tissue. If you look by transmission electron microscopy at the dermis of normal skin, so the part that we make leather out of, you can see that the fibrils of collagen are organized in arrays of parallel fibrils. You can see one array here that comes out the screen, and then one here that goes up that is cut lengthwise, and then you can see the typical striation of the fibrils. If you look at the cam, you see a very similar structure of compact parallel fibrils that are striated. But if you look at a collagen gel, you'll see very few fibrils. Most of the collagen is in fact amorphous. It's not well organized. You can, and that's why this collagen gel is very weak mechanically. And of course, you can, by physical, chemical processes, compact this collagen and cross-link it to get it to be mechanically strong, but you still won't get fibrils formation. And once you implant it in the body, the disorganized collagen will be digested by the body by the innate immune system, because it's its job to find degraded collagen and to digest it. So it makes space to rebuild collagen. That's, part of the healing process. So why do we need we need vascular graft? Well, because in vascular surgery, we use them to do things like bypasses of clogged vessels. So the well-known heart bypass or coronary artery heart bypass. We use them in the leg in the procedure that's called, that's a peripheral bypass. And then, there we go. And then one common use of a graft is for hemodialysis access, so that we can connect an artery and a vein together with the graft, and then we can puncture this graft with 2 large needles 3 times a week, so we can connect a patient to an hemodialysis access to clean his blood. There are synthetic grafts out there commercially available, but these grafts tend to thrombose, and the smaller their diameter, the more thrombosis. We consider that below 5 millimeter in diameter, the outcomes are unacceptably low. And so that's why we don't use it for coronary heart bypass. That's why, because below the knee, the outcomes are poor. And in hemodialysis graft, the diameters are bigger. However, the grafts are being punctured, and there's other issues, which also leads to poor outcomes. These synthetic grafts made out of PTFE or Dacron don't re-endothelialize well. Because they're made of foreign material, they are a cause for chronic inflammation, which can lead to their failure. And they are also susceptible to infections. For all these applications, there are natural vessels options where we do a graft using the patient's own vessels. And these function much, much, much better, but they are not always available. So as a result, it makes perfect sense to try to make biological grafts, human biological grafts in the lab, so we can have them accessible all the time. So the cell assembled matrix is really a platform, and I'm here to talk to show you how you can consider this a biomaterial, although it's probably more bio than most materials, and how we can do different things from the sheet. We have different ways of using the sheet. We can use it directly and take a sheet-based approach, or you can use a textile approach or a particle-based approach. So we've used the sheet-based approach previously at Cytograph for about 15 years, and we've turned this project from a benchtop to a bedside. making these sheets, rolling these sheets in tubes, multi-layered tubes that we put in bioreactor for months to get the fusion of the different layers. We can do that twice and get a very sturdy vessel that then at the end we can seed with endothelial cells and reimplant in the patients. And these are completely living autologous grafts. And one thing that we observed over these 15 years is 3-year patency as hemodialysis access graft in patients. These were very old patients, very sick patients, so this is an extremely good outcome. And we've also seen that we can actually do allogenic grafts. In a few cases, we used grafts from one patient to another without the endothelial cells and saw no clinical signs of rejection. The thread-based approach or the yarn-based approach, the textiles approach, is what we're going to talk about today. And the particle approach that make them injectable is something we can talk about another day. So why do we use a textile approach? Well, because it allows us to not worry about fusion of the layers. We don't need a bioreactor, which are costly, time-consuming, expensive devices. We don't need to worry about the cellular processes, which are finicky and change from patient to patient. We don't need to worry about delamination, which is a concern for any structure that's laminated. And overall, the assembly process is about 3 times faster if we use a textile approach than a sheet-based approach. Also, textile approaches are much more versatile from a mechanical point of view. We can control directional mechanical strength, local mechanical strength. We can also control things like porosity, all things that would be extremely difficult, if not impossible, to do with a sheet-based approach. Also, like every textile approach, it can be automated. So if you want to make textiles, you need to make yarn. And the way we make yarn is we take our sheet. Once our sheet is good, we freeze it. Once we're ready to make yarn, we thaw it, and then we run it in a machine that will make very even incisions of the sheet, longitudinal incisions. And as you can see, the sheet will retract on itself to make yarn that we call ribbons. So we can make ribbons of different sizes. You can see a 5-O-proline as a scale here. And we can further process the ribbons by twisting them into what we call threads, which have different mechanical properties and are more dense. No matter which yarn we make, we can dehydrate them, spool them, store them at -80 basically forever. And the day we want to construct something, we take them out, we rehydrate them, and then we start assembling the construct. So we call this process devitalization, and we've studied it with Laure Magnan, a student of mine. And we use it because we find it a very gentle process to keep the matrix stored so that we can have a more flexible manufacturing process. If you look at the cross-section of the histology here, you see that there is some shedding of the superficial cells, but all in all, it seems pretty undamaged by the process. We have seen that in terms of thickness and in terms of mechanical strength, this devitalization process has no effect on the matrix. This matrix is very complex. It's not only collagen, it has at least 50 different extracellular matrix proteins, so it potentially could play a very complex biological roles and varied biological roles. And then we started playing with the yarn, and we did a few things. We took the yarn and we created multi-filaments, so more complex yarn by braiding or twisting, things that are done commercially with sutures, for example. We tested knotting of the yarn. We actually have used it as a suture material. Then we did multiple knots, so we can do crocheting and knitting, which are knot-based assembly techniques. But most important, most interestingly for us, we focused on the weaving. So here we've colored the threads in pink. So you can see two sets of threads. You can see the longitudinal threads. Well, actually, they're horizontal here. It's a set of different individual threads. And in the other direction, a transverse thread will go over, under, and back and forth, etc. So that's the basic structure of a plain weave, which of course is not very tight here, so you can see the structure. Now, we want to make tissue engineered vascular grafts, so we'll need a circular loom so we can weave our threads into a tube. You can see it on the right here with the longitudinal threads that are attached at the top and the circumferential threads, which is pulled by the weaver here. These vessels, our first batch of vessel has a very high burst pressure, about 6,000 millimeters of mercury. That's about twice as strong as a human artery. Probably too much at this stage, but it's easier to make them weaker than stronger. In terms of suture retention, which is a very important aspect when you want to implant these grafts, we finish the ends using a weaving technique to get the very clean end. And then we run a suture and then pull it out, see how much strength it takes. And in this case, we used 7-0 Prolene, which is used in surgery. And in most cases, the Prolene suture would break before the vessel. That's why we don't have a pure number here. We have 6 Newton as a value. Of course, as a woven graft, we're worried about, we're worried about water tightness. And here is a graph under full arterial pressure, so 120 millimeters mercury. And you can see when I run a needle through it, there's a squirting of the water. You see that if I don't move the suture, it's very tight. If I pull on it, it will squirt, which is what you would see exactly in a normal vessel. You see there's very little leakage. This is water. And 10 millimeters per minute per centimeter squared is a very low porosity, permeability, and completely suitable for implantation. Of course, you can have the nicest vessel you want in vitro. What's important to know is what's going to happen in vivo. So to test this, we implanted these threads in the subcutaneous space of nude rats. These are human threads, so the nude rat will not respond to the human nature of the threads because they're nude rats. And we can see that 6 months later, we can find easily these threads under the skin of the rat. We can even explant them. And for those who don't think that these rats can degrade anything, we implanted a reconstituted collagen membrane that's used clinically. That is made out of collagen, but that's been chemically modified. And you can see 2 weeks later, it's already completely eaten up. It's all brown, and you cannot even recover it to do mechanical testing. So the rat has a functional, innate immune system, not a acquired or specific immune response. So one of the nice things about implanting a long thread like that is we can explant it and measure its mechanical properties. What we see here is that at T0, we're at 100%. And we see that after 2 weeks, we've lost, upon implantation, basically, some mechanical strength, probably due to the inflammatory response. And after that, the mechanical strength is quite stable over 6 months. If we compare to our twisted thread, the twisting at T0 weakens it a little bit. We also did something like decellularization using a process that's, well, I won't go into that, our own process, where we see we have no mechanical strength loss. And we did a gamma sterilization where we did see some mechanical loss at the T0. Now, with time, we see that the twisted thread keeps its mechanical strength throughout, probably because it was very dense at the beginning and it was less susceptible to the inflammation response. The decell process did not seem to affect the response, at least not significantly, whereas the gamma sterilization seems to lead to a degradation of the product that is ongoing at 6 months. In terms of histology, this is at 2 weeks, devitalized graft ribbon. You can see here the different layers of the ribbon that is folded upon itself, and this is the dermis of the rat. You see very little inflammation, if any. You see already, however, little blood vessels that are appearing within the thickness of the cam. And if you look at 6 months later, it's basically unchanged, maybe a little less cells around it, maybe a little less inflammation, but the ribbon is still there, which shows that there's no innate immune response to that material. Now, it's great to do nude rats, but for vascular studies, it's not really great because it's just too small to be clinically relevant. With the student Johan Torres, who's worked quite hard to try to reproduce this in a large animal, we've created an ovine model. And as you can see, we can create very nice ovine sheets, and these can be cut. These can be assembled in blood vessels that have similarly impressive mechanical properties. And this will allow us to do long-term study in a clinically relevant model because of the dimensions, and in a allogenic model, which is what we want to do eventually in the clinic. So in conclusion, I hope I've shown you that this cam is really a biomaterial because it comes in multiple forms, shapes, and sizes, but it's unique in its ability to integrate in the host and provide very long-term stability. It is very easy to use it as the basis for human textiles, which can be rapidly assembled, eventually can be automated, and it's very tunable in terms of shape and mechanical properties. And finally, I hope you've seen that the vascular grafts that we make out of this technique are strong, suturable, and leak-proof. So I'm going to thank all my team at Cytograph and our friends that helped us do clinical trials, as well as the NIH, who was instrumental in starting this company, and my new team in Bordeaux and my various funding agencies. Thank you very much, and I'll finish by inviting you to come to Tokyo to the ISACB meeting in March 2021. Thank you very much.
Thank you very much, Nico. Nan has joined us, so please allow me to introduce Nan Huang, and she'll pick it up from here. Nan is the Vice Chair of SFB's Cardiovascular Biomaterials Special Interest Group. She's professor in the Department of Cardiothoracic Surgery at Stanford University and principal investigator at the Veterans Affairs Palo Alto Healthcare System. Dr. Huang has completed her BS in Chemical Engineering from Massachusetts Institute of Technology, followed by a PhD in bioengineering from the University of California, Berkeley, and the University of California, San Francisco Joint Program in Bioengineering. Prior to joining the faculty, she was a postdoctoral scholar in the Division of Cardiovascular Medicine at Stanford University. Her laboratory investigates the interactions between stem cells and extracellular matrix microenvironments for engineering cardiovascular tissues to treat cardiovascular and musculoskeletal diseases. Nan, take it away.
Great. Well, thank you for the introduction. I'll start with the Q&A sessions. Please feel free to use the chat box to ask your questions for today's speakers. I'll just kick it off with the first question. So Nico, what's the difference between a devitalized and a decellularized graft, and why are you focusing on devitalized?
Decellularization, as you know, involves using a lot of products like salts, solvents, detergents, and all these treatments will remove some of the extracellular matrix. So our idea was that unlike transplants, we only have fibroblasts. There are no immune cells, there's no blood vessels, there's no cells that are easily picked up by the immune system. And our clinical studies have suggested that we can implant an allogenic graft with cells in it without immune response. So our idea is, why is why do decellularization if you don't have to? It can only be bad. So we've tested decellularization as an option, and we still are keeping this in our back pocket if we need to. But the idea is try to preserve the matrix as much as possible, because this is a costly and involved process, even if as tissue engineering, it's not maybe the worst. But so it has to work, it has to bring some special outcome. And for that, we think that we need to keep the matrix as native as possible.
Great. And another question comes from Ekaterina Kachuk, which is how long it takes for the cell assembled matrix that has shown strength. And also you mentioned about a bioreactor. Does the bioreactor require during the process where cells produce collagen layers?
No, so the idea, so first the sheet basically you can keep it as long as you want, and it gets stronger as you keep it. It's pretty impressive. We had some sheet that we've kept for 6 months, and they were getting stronger and stronger. Typically, all the one you've seen are typically 8 weeks, but you can do less, you can do more. It just depends on what strength you want. So for example, we see that our vessels are very, very strong. Maybe we want to use younger sheets, or maybe we want to cut thinner threads. These are things to consider. The bioreactor, in this process, there is no bioreactor. That's the big advantage. It's just flasks and standard tissue culture techniques.
Great. And the next question comes from Kelsey Wilson. It's regarding the gamma sterilization process. If that process is deleterious, how are you going to sterilize these? Have you used EO or autoclave assays?
So that's a great question. We have shown before that we can produce these completely sterilely, which would not require any sterilization. Obviously, if you're able to work in less sterile conditions and sterilize at the end, it might be in terms of cost and manufacturing, it might make things easier. And in terms of regulatory agencies also, they like to see final terminal sterilization. So I have a student that's Diane Potard in my lab who's currently testing various sterilization techniques, and should have a paper in maybe a year or two.
Great. Another question from Samantha Gazanfari. It's regarding your choice of weaving. I guess the question is why weaving over other approaches?
Yeah, so maybe she was referring about to knitting, because there are knitted grafts currently available commercially. Knitting is more complicated to do on your own, because we won't be knitting with 2 little needles. So that's one aspect. Knitting is also typically much more porous than weaving, and knitting is a knot, and knots are very hard on the fiber. They weaken the fiber much more than weaving. And our yarn is not plastic, it's not PTFE, it will never be as strong as nylon. So we chose weaving for this reason, but it doesn't preclude us from trying knitting. We've had our eye on some small startups or small companies who do commercially knitted grafts, and we'll see if we can adapt their instruments to do that with our thread.
Great. Well, we'll end with one last question in the interest of time. And this is really regarding your scalability approach, scalability into large animals and scalability in engineering larger vascular grafts. What are your plans for doing that?
So by changing the way we assemble the graft, although we've shown that we can do clinical trials with this material, we're basically going back to zero almost. So there's a long way to go before we have issues of mass producing. However, this is a much more mass production friendly approach because there's no bioreactor. All the culture is done in standard flasks. So ultimately, you could even automate the culture, which is currently feasible to have robots that do full culture from flasks. And the manufacturing of the graft is quick, it's simple, and eventually the weaving is, of course, completely automatable. So in terms of mass production, it'd be much more interesting. And for the animal study, well, the animal study is ongoing. We are learning to make the best vascular grafts out of ovine material, and then we'll be doing ovine implants, and we'll be in a good position to look at the remodeling for very long-term remodeling without having immune issues.
Great. Well, thank you very much for answering these questions, and thank you for your talk. For those who are joining us now, this is a joint webinar by the Society for Biomaterials and the International Society for Applied Cardiovascular Biology, otherwise known as ISACB. Today, before I introduce the next two speakers, I want to give you a brief introduction about ISACB. ISACB is an international organization founded in 1987 to improve the quality of basic and applied research in all areas of cardiovascular biology. Its goal also is to enhance communication between basic scientists, industry scientists, and clinicians. And ISACB organizes numerous activities, including a biennial research meeting, career development opportunities, and social networking opportunities. As Nico mentioned, our upcoming biennial meeting will be held in Tokyo in March of 2021, and you can learn more about ISACB at our website, isacb.org. Next, I will be presenting our second speaker of today, Dr. Vahid Sarpushan, and he is a faculty member at the University of Emory and Georgia Tech. He received his bachelor's and master's in material science and engineering at Sharif University in Tehran, and his PhD in biomaterials and tissue engineering at McGill University. While he was a postdoc at Stanford, his research was focused on developing a new generation of engineered cardiac patch devices to repair damaged heart tissue following myocardial infarction. And in 2018, he joined Emory University and Georgia Tech as assistant professor of biomedical engineering and pediatrics. His group works on 3D bioprinting based tissue engineering and disease modeling projects. And we're really excited to hear his talk.
All right. Thanks, Nan, for a kind introduction. Can you guys hear me well? And I believe I'm sharing my screen already. So let me just go to the presentation mode. All right. Yeah. Hello, everyone. My name is Vahid Sarpushan, assistant professor of biomedical engineering and pediatrics at Emory and Georgia Tech. So about a year ago, Dr. Bazar Heaton and I joined forces and basically have been working together on multiple collaborative works. And we're going to be basically talking to you about the, a few of these projects that we're working together. So I'll go first, and Holly is going to follow with some of the cool clinically more relevant stuff that we are doing in our lab. Nico nicely talked about weaving and knitting as different manufacturing techniques for creating scaffolding systems. Here is another biomanufacturing technique, 3D bioprinting, which is relatively newer than other techniques. And speaking about scalability, that's basically one approach that could basically address some of the clinical or industrial needs for creating larger scales of tissues. So before I get started, a quick piece of advertisement. Find me on LinkedIn. I would be happy to connect with you guys on LinkedIn. And also here is our lab website, sarpushanlab.com. Please, check our website for our latest news, discoveries, and research activities that are ongoing in the lab. And here is the roadmap for our joint lab research. Like many other tissue engineering labs, we start from the top right corner, working with different biomaterials, cells, and small molecules. as the building blocks for tissue engineering products, and going all the way basically with the ultimate goal that is basically on the bottom left corner, creating new drugs, new therapies, interventional procedures that could be practiced in the operation rooms, and maybe some screening and development of platforms for the, disease modeling. So these are basically our ultimate goals. Today we're going to talk to you about two specific projects. I will talk to you about the engineered patch devices and how we are basically using our 3D bioprinting techniques to create different engineering devices. And Holly is going to talk to you about the modeling of congenital heart disease. So for the patch devices, most of our work is mainly focused on cardiovascular and tissue engineering and patch structures, but we also have some collaborations with other labs on bone, liver, and cancer, and more recently we have also started working on brain and lung tissue printing. Like I said, mostly in terms of in form of collaborations with other labs. These are some of the key concepts for our engineering patch projects. We mostly work with functionalized biomaterials. So a lot of our research in the lab is focused on creating new biomaterials or new generations of materials that could be used as bioinks for 3D printing. We have a special focus on vasculature and creating vascular structures in our scaffolds. So I'll talk about that aspect as well. CT and MR visibility, being able to monitor and track the patch in vivo after implantation is a very important aspect that we are trying to basically address. We use a lot of nanobiomaterials for our functionalization purposes of our biomaterials, and we basically add nanoparticles for different purposes. Again, I'll touch up some of the specific applications for nanomaterials. And finally, we are trying to make patient and damage specific scaffolds, mostly for our in vivo regenerative applications. And Holly will talk to you about the modeling of congenital heart disease. I'll leave that to Holly. She's gonna do a great job after me. But the engineered patch devices. Here is basically the toolkit that we have developed over the years in our lab. Again, working closely with Dr. Bazer Heaton. She's a pediatric cardiologist, a clinical research faculty. So, together we have developed basically a combination of different technology that we're using, advanced imaging, including MR and CT. Of course, 3D printing and 3D bioprinting are main technologies in our lab. You'll see most of our work are using, these technologies. We use IPS technology to create, patient-specific or disease-specific cellular structures. A lot of nanobiomaterials work, micro and nano mechanical analysis. As a material scientist by training, I do have a significant interest in characterization of mechanical properties of our bioprinted structures. We work a lot with bioreactor systems, perfusion bioreactors, to actually perfuse our constructs with the flow. We working with our clinical faculty, we do a lot of interventional procedures in our bioprinted platforms, which we believe is a very novel approach. And finally, we do a lot of computational modeling, to go in parallel to our experimental works. So this is the kind of cycle that we have designed to explain how our basically workflow is for 3D bioprinting of functional tissue structures, mostly cardiovascular, but again, we use the same workflow for other types of tissues as well. We start with panel A, medical imaging, either CT, MR, or other medical imaging modalities. We 3D reconstruct those imaging data to create a CAD model, a digital model that could be actually transformed into an STL file, this layered digital model, which is translatable to actually a 3D bioprinting device, as you see in step C. The majority of our work actually is focused on this step C here, which is basically to prepare a bioink, characterize the bioink, and actually do the bioprinting step. As you see, the main, one of the main building blocks of our bioinks are the biomaterial that we have to use as the base of our bioink. And then we mix it with different cells, small molecules to actually create a functional ink. Our bioprinters, I'll introduce our bioprinters shortly, but they are able to print with multiple inks at the same time, up to 8 different inks at the same time, which is very impactful for 3D printing and tissue engineering applications. So we can actually create these 3D structures, which are highly heterogeneous, structures made of different cells, different biomaterials, with different functionalities that could be tested in vitro or in vivo as a patch for regenerative applications mostly. And this cycle actually could go back to step A again and do medical imaging of implanted scaffolds to see how these scaffolds are doing. So here is the machinery that we have in our lab that we use to basically create these scaffold systems. On the left side, you see a bioassembly bot, a 6-axis robotic arm printer, which is one of the most sophisticated bioprinters in the market. It enables you to print with up to 8 different inks at the same time at a very high resolution. It can also rotate in different angles, so it gives you high flexibility and robust printing manufacturing options for your structures. Also, we have a Cellink BioX on the right, and also from Cellink company we have Luminex, a stereolithography bioprinter, a new generation of bioprinters, and also an Alevi 2. We also have a different types of regular 3D printers, which are used for printing plastics. And together with our bioprinters, this machinery basically enables us to create complex structures for different tissue engineering applications. The project that I want to specifically talk to you about today is an engineered cardiac patch, since the focus of this webinar is on cardiovascular. Like I said, majority of our bioprinting works right now are focused on printing cardiac structures, and this cardiac patch is meant to regenerate the adult myocardium following a heart attack, a myocardial infarction, or MI. So the patch that we've designed previously is basically an acellular patch, no cells implanted or encapsulated in the patch. We loaded the patch with a peptide, FSCL1, which is basically known to be cardioprotective. It enables to trigger cardiomyocytes proliferation, angiogenesis, and some other mechanisms. And we already published this work. You can refer to these publications, which kind of nicely cover how the first generation of this patch device helped to regenerate the adult myocardium following a heart attack. And these are some animal models that we did back in Stanford. This is mouse study where we stitched the patch on the mouse heart after inducing myocardial infarction. Results were promising. We showed that we can significantly recover cardiac function after implanting the patch. And the pig studies as a preclinical phase, we also again showed them that applying the patch on the surface of a myocardial infarction can significantly help in restoring the cardiac function and also reducing the scar size, as you see with the cardiac MRI. While there were a lot of positive mechanisms of action for this regenerative effect that we saw, there was yet a list of shortcomings in the patch design that we had. There was lack of vasculature. This patch did not have any inherent or preformed vasculature to it. It was a solid, basically, piece of collagen gel. It was not patient specific. We made a generic kind of round shaped patch that was basically transferred to the operation room, and they had to basically cut it into pieces to basically cover the size of the infarct that they have in the operation room, which was a really labor intensive work in the operation room. There's always risk of inflammation. I skipped this one. It's also, we were also unable to track the patch in vivo. So once we implanted onto the heart, we couldn't really see or monitor how the patch is working after implantation. The delivery of this patch was kind of aggressive. We used a left thoracotomy, which is basically opening the chest, getting access to the surface of the heart. It's really invasive for a patient who is already he had a heart attack. And also to stitch the patch on the heart, we have to basically use sutures, which could actually induce extra injury and damage to the heart tissue. And also risk of erythmogenicity. We have a patch that doesn't have any contractile cells sitting on a piece of heart that is supposed to be contracting, and this mismatch could result in erythmogenicity, which could be highly costly for these patients. So right now in our lab, basically we're trying to address these issues, these shortcomings of the previous design of our patch using 3D printing technologies. I'll talk about a few of these works that we're doing to address some of these limitations. So I mentioned the lack of vasculature in the previous design. So here we are basically trying to 3D bioprint vascular cardiac patches. using direct printing of cardiomyocytes, we differentiate iPS cells into cardiomyocytes. These are beating cardiac cells in a dish in the laboratory, and then we remove these cells from the substrate, suspend them in our bioink, and start printing layer by layer. This video hopefully is playing on your end as well. It shows you how we actually print layer by layer and line by line the printed the patch structure based on the CAD design that you see on the top left corner. So we end up basically, after the printing process is complete, we end up with a piece of tissue that could be cross-linked, in this case using UV light, and therefore after it's basically ready for use in the animal studies in this case. So here some immunohistochemistry which shows these printed cardiomyocytes in this highly dense structure show some signs of cell-cell connection and also maturation. In a larger view, you're hopefully able to appreciate that there are some sarcomeric structure, organized sarcomeric structure in these cardiomyocytes, which suggests that this could be moving towards more maturation and functional cardiomyocytes. One of my new PhD students, Bo, she's working on basically more biomimetic vascular structures by creating these sorts of vascular trees, multi-scale vasculature with basically vascular systems in the scale of artery, all the way going to arterial and even capillary scale in the same patch. These are some bioprinted samples showing how this could be actually translated into a piece of tissue. And once we have printed this structure, this is a kind of complex slide, but what the bottom line here is basically we can print different geometries of vasculature and then connect them to these perfusion systems that are custom designed. We mostly 3D print parts of our perfusion systems. And within these housing chambers that you hopefully see here, we have our printed vascular structures that are perfused with culture media for up to 2 or 3 weeks. We have been able to do this. Works. The other limitation that I mentioned is that the patch is not patient-specific, and we are not also able to track the patch in vivo after implantation. So again, our PhD students in the lab, they're working on 3D bioprinting of patient-specific cardiac patches, and we had this Emory I3 award for this work. But basically the bottom line for this process is that we start with the medical imaging, mostly MRI data of the patient who comes to the clinic with a heart attack. And based on the MRI data, we can actually identify the infarct and the peri-infarct areas and create a CAD design model that is exactly matching with the shape and geometry of the defect of the myocardial infarction. So the patch that we 3D print is actually exactly matching with the geometry of the myocardial infarction. Not only the geometry is customized, we also customize the vascular structure that we have inside the patch to match nicely with the host tissue viable vasculature that already exists in the peri-infarct area. Along those lines, we again, one of our other PhD students are working on 3D bioprinting of different contrast agents in our patch devices. We are right now working with 3 different contrast agents, namely gold, gadolinium, and iodine, to basically label different parts of our patch devices for different purposes. We have the periphery of the patch, the vasculature, and then also the therapeutics labeled with different contrast agents, which enables us to non-invasively track all these functionalities of the patch after implantation. Some preliminary results, how we are basically working with different nanoparticles and also molecular contrast agents and print them into different patch structures, more complex geometries. The other limitation that I mentioned is the risk of inflammation. That is always the case for implants, biomaterial implants. Our research specialist Andrea is working on 3D bioprinting of antibacterial or bacteriostatic patch devices, basically patch structures that are resistant against bacterial growth, and at the same time these patches are MR visible. For this purpose, we're using iron oxide nanoparticles known as spions. And as you guys are probably familiar with these nanoparticles, they are inherently antibacterial. So by incorporating these nanoparticles into our ink, we are able to print patch devices that are showing significant resistance against bacterial growth. And therefore, we can actually create some implants that would have less risk of inflammation or other complexities related to implant rejection. And also at the same time, like I said, they are MR, they give you a significant MR contrast, so they could also be used for imaging. Last work that we're doing on cardiac patch is basically trying to fix or address this aggressive patch delivery that I mentioned. We are working with a couple of colleagues at Emory and UAB to basically create a pericardial delivery approach using a transcatheter technique that comes from pericardium to very less invasively deliver the patch onto the surface of the heart. And we are planning to basically do some ex vivo experiments soon on that. So with that, I'm going to just wrap up this first part of the talk, which was how we are using our engineering approaches to create different patch devices, mostly for in vivo experiments. And I'll switch to Holly, my colleague, to talk to you about modeling congenital heart diseases. Holly, take it away.
Great. Well, let me introduce Holly in the meantime.
Sure.
Holly Balzer-Heaton is an assistant professor at Emory University with a clinical focus on pediatric interventional cardiology, who is specializing in pulmonary vascular diseases at the Children's Healthcare of Atlanta. As a basic scientist, she's interested in modeling congenital heart lesions and primarily focuses on pulmonary vascular stenosis and endothelial dysfunction. In a joint effort with the Heath lab, her lab explores the cellular mechanism of pulmonary vascular disease. And so we'll proceed with Holly's talk and then do a combined Q&A session for both speakers.
Wonderful. Thank you so much for the opportunity to talk. And I think that we will see if we can share this now. Let's see. Okay, can you guys see my slides okay there?
Yes, we can.
Okay, wonderful. So thank you, Vahid, for talking about the engineered patch devices. And as he mentioned, our lab very much is in an interesting collaboration between, engineering and clinical medicine as well. And so I'm going to talk to you about some of our opportunities for modeling congenital heart disease. We have several areas that we're exploring. One is modeling the developing human heart and exploring opportunities for understanding shear forces that play a role in cell development in a developing fetus. We also will talk about, touch base on our hypoplastic left heart syndrome model as well, and pulmonary vein stenosis and also pulmonary artery stenosis and atresia. Certainly clinically every day we see that there are opportunities to improve our understanding of the congenital heart disease process. And so our plan is to use a printed platform to study these various congenital heart diseases, primarily the ones that I mentioned, but certainly this could be applied to any disease state that we see in the clinical setting. As an interventional cardiologist, I know certainly there are ways that we can improve what we do. Surgery has vastly improved outcomes over the last 50 years, but now we are at a point in which our therapies are not improving at the rapid pace they had in other years. And I think part of that is because we just really have a lack of understanding what happens from a developmental standpoint. Looking at this figure, we're looking at the embryonic heart. This is a day 22 representation of a fetal circulation. And the fetal heart begins as a simple tube that becomes complex over time and takes a complex twisting shape as it develops into a 4-chamber heart with 4 valves and outflow tracts. And what we see here in figure A is a representation of this simple tube structure, but one can imagine that the inflows and outflows associated with the developing human heart and the shear forces that are applied along the wall can vary significantly depending on systemic vascular resistance states within the placenta and the fetus. And so obviously that's very difficult to study in a human, and so we are using 3D bioprinting in a live functional model in which we have endothelial cells that are embedded in a hydrogel or gelatin methacrylate bioprinted tube. We have inflows and outflows that allow us to perfuse this structure that we can then explore with 4D MRI, ultrasound, and CFD. In figure E, we were able to take ultrasound images of a fetus and extrapolate some of the linear heart tube that becomes more complex over time. This is very early in fetal development. And you see again that there are inflows and outflows that we can apply force and flow to and understand the cellular changes along the wall for the more complex twisting structure of the heart tube. In addition, we want to also understand what happens as fetuses get older, and this is a fetal heart also by fetal ultrasound. You can see that we were able to take the fetal ultrasound, turn it into a CAD model, and do 3D printing with resin, and also then extrapolate that into the hydrogels that we just mentioned. This allows for inflows and outflows. This is a non-valve structure, but it at least allows us to understand flow changes. There are individuals who are alive at 33 weeks gestation, but it's not in fetal circulation. And so we're trying to mimic the fetal circulation that one might encounter. And then K is simply showing you how we've isolated the left ventricle and use the same techniques as I mentioned to take the ultrasound of just that simple structure and turn it into something that we can study flow and shear stress as well as cellular changes. These structures are much larger than what would be found in a fetus, in fact, over 200 times the amount. However, you can see just based on this photograph how small these structures are that we can apply flows that are scaled appropriately. Next, I want to talk to you about the application for pulmonary artery stenosis and atresia with a very rare disease, however very complex, called MAPCAs, which is major aortopulmonary collateral arteries. We became interested in this at various points in training. I've come into contact with very complex pulmonary artery anatomy, and really we don't have great ways to treat this. Surgeries are performed without modeling and simply bringing the pulmonary arteries together. Vahid and I both had some visions to making this a little bit more of an approach that we could understand what is best for the patient and how to decrease the morbidity and mortalities that they experience after surgical intervention. We recently published this paper in JAHA looking at the 3D bioprinted model that we created for the in vitro analysis of treatment planning for these specific patients. And this can be extrapolated as well to patients with other types of pulmonary artery or vascular anomalies, of which we have many in congenital heart disease. This paper went along the concept to understand how we might be able to bring these pulmonary arteries together. And just to give you a background, these patients are born with pulmonary arteries that are not connected to the right ventricle, but rather come off anomalously from the aorta. And the surgeon simply brings these, I say simply, certainly it's very complicated, brings these pulmonary arteries together via patch and sewing techniques, angioplasty techniques, and then unifies them with a conduit. And while all of the pulmonary arteries can be brought together over time, what we see clinically is all of these connections can become very narrowed, causing significant morbidity with right ventricular hypertension. And so this is an angiogram that I performed in the interventional cath lab. And this is a patient that underwent that surgery I just mentioned, where their pulmonary arteries were brought together years prior to this angiogram. I'll just direct your attention to show you that there are multiple areas along this vascular bed that are very abnormal. And in fact, this area right in the center shows a pulmonary artery that's no longer connected to the vascular bed. And so this patient relies on a lot of flow having to go through the pulmonary vasculature and then coming back to fill that portion of the lung. Clearly that's abnormal and has caused this patient elevated right ventricular pressures. And so when I see a patient like this, the surgical techniques that we have are limited to grab the vessel that is now atretic. We propose that perhaps we could take that angiogram and turn it into a 3D printed model that we could simulate some various techniques that could be performed in the cardiac cath lab or also in the operating room. We took the angiogram that I showed you from a 3D angiographic spin similar to a CTA stack and turn that into an STL, and we're able to print it with resin, bringing it to the cath lab that I could inject and move catheters throughout to do some planning. In addition, we found that perhaps the best connection would be to bring the atretic pulmonary artery back into circulation with the main pulmonary artery. And it seems very simple in concept, but clearly is quite complex. In between these two vascular beds, we have airway and lung parenchyma. It's not just a simple connection. And so planning that and understanding how one might be able to perforate vasculature and not cause a patient to have demise is something that we were interested in doing. We proposed that we could make a live functional and perfusible phantom that we could test all of these parameters after connections, including cellular behavior, to understand if we were to go through such a complex procedure, would we benefit in the long run? Looking at how we approach this problem, we have two different patients represented here, but we have many that we've been able to look at this same technique. In panel A, we've taken a CTA of a neonate and turned that into an STL file, printed it, and then are able to perfuse it in the cardiac cath lab with physiologic flows to understand the flows that go into each major aortal pulmonary collateral vessel. And in B, this is the patient that I referred to previously, and this is in blue showing the airway. The yellow is showing the vasculature that is no longer connected. We're able to extrapolate that and again, use that in the cath lab. The proposed mechanism of bringing these arteries together is then something that we use to simplify a model where you have a patent vasculature and then one that's atretic, and how we might be able to use conventional interventional tools to create that connection for study. We were able to use a 3D bioprinted housing and then did 3D printing inside of that housing using Pluronic as a sacrificial material to make the vascular tubing connections. Again, we have a patent pulmonary artery representative and then an atretic representative. We were able to introduce interventional tools, and I could create or establish this connection that we intended to do with this patient at our forefront, at the mindset. So we have, just showing you in panel 1, this is a vasculature that's showing you, again, under X-ray angiography, the vessel is patent in panel 2. In panel 3, we take a CTO wire or a coronary total occlusion wire, and we're able to perforate the gelatin methacrylate that has the same density and the same overall stiffness as a pulmonary artery, and we're able to recanalize this model using stenting techniques that are currently available. In doing so, the angle and the diameter of this connection can change significantly. And so we started to begin to explore what these connections meant in terms of restenosis in the future. As Nico had mentioned, we know that post-surgical interventions, particularly using grafts and stents, we get a lot of new intimal proliferation. Some of that is thrombosis, some of it is cellular overgrowth. And we think some of that is because there's a turbulence or an eddy that is developed at the connection site. So using CFD, we're able to model several different connections, diameters and geometries to show us the most laminar flows that we could achieve in these patients. This is just showing you a representative of a 3mm vessel inserted at 45 degrees. This video is showing you the procedure itself. We have an injection in the patent pulmonary artery. The wire is going toward the atretic vessel. And again, this would be something similar to what we see in the cath lab. Some of this is relatively blind, and so we wanted to simulate that experience. We have a flexible coronary wire going into the atretic vessel. And again, you see that the wire does not simply perforate that vessel. The gelatin methacrylate really does simulate the stiffness of the pulmonary artery bed. We're able to introduce catheters into the model, just as we would, and then establish a connection and then subsequently putting a stent to open up and hold that connection, which is current available therapy in the cardiac cath lab. This is the setup that we bring into the lab. What you don't see is the II or the intensifier above and below this. It's a small setup, but easily transportable into the cath lab, and I can use sheaths and catheters that we have available right there that we would utilize in the patient as well. This is a representative of the CFD that I mentioned earlier, and you see that there is a small amount of turbulence and eddy here, but this is one of the more optimal connections that we were able to establish. Again, one might be able to say that as you make this sort of connection, you can decrease the overall stenosis in someone with a more laminar flow pattern. It is yet to be determined, but something that we're studying with cellular interactions currently. Just showing you a video, benchtop. This is not in the cath lab. This is just what it would look like if you were to view the connections. And you can see that there's an established connection in the lower panel. We also are working on a generation 2 model, which is an interstitial model that would allow us to have to simulate trachea, airway, and also lung parenchyma in between the two areas that we intend to anastomose, but allow us to understand some of the damage that ensues when we're trying to make these sort of connections in a patient. In addition to the pulmonary artery modeling that we're doing, we also have extended this into looking at pulmonary vein stenosis. Here at Children's Healthcare of Atlanta, we have one of the largest cohorts of pulmonary vein patients in the country. There are just a few places that tout being experts in this area, and we have one of the largest pulmonary vein programs here. What we don't understand is how we are really able to alleviate stenosis for pulmonary veins without having significant intimal overgrowth. Again, you see a theme. This is a similar problem that we see over and over again. So what we're looking at here is creating a model that we can apply physiologic flows, introduce therapies, and see how those flows change. We started with a very simple model, which is just the vascular tube, with an area of stenosis that was greater than 50%. We made several iterations to our model, and we were able to make this a little bit more complex, as you can see. So in the bottom right-hand corner, you see that this is simulating a pulmonary artery, pulmonary vein bifurcation. The flow would come from the left and go toward the right, as it would in a patient, and the pulmonary vein stenosis would be right before the entrance into the left atrium. I'm then able to introduce catheters and wires and alleviate the stenosis, and again, we can apply flows with cells inside of this and to understand how the cells change over time. So I just wanted to touch briefly on the unique setup that Vahid and I have in our lab. I'm an MD PhD by training, but having another collaborator is paramount to making a clinical translational lab work. And I always appreciate his understanding and appreciation of what I'm doing clinically and vice versa. It really is two different worlds, and bringing those together is very important. The other piece is sharing credit, and we both do a very good job of, before manuscripts are written, before we talk about how we're going to co-mentor students, that we really share credit appropriately. Co-mentoring is a huge component of what we do with undergraduate students, masters, PhD students, and clinical fellows, because some of them have a more basic science lean and others have a more clinical lean, the research specialist, and of course, our postdoctoral fellows. And then having shared established collaborations between a clinical team and also translational science team. I really want to thank our lab. We have a wonderful group that works with us, our research specialist, Andrea and Lalani, our postdocs, Martin and Lequin, all of our grad students who I know that Vahid touched on, Carmen and Bo, and some of the work that they've done. Alex is a past student who's contributed a great deal, and all of our undergraduate students. We are also really fortunate to have wonderful collaborators and those that work with us for all of the projects, both clinically and from a basic science standpoint. I just want to thank you all again for the opportunity to chat about what we're doing in our lab.
Great. Well, thank you for a stimulating talk. And now with both Vahid and Holly present, we'll have a combined Q&A session. Please feel free to use the questions tab to ask your questions below. And maybe I'll get started first. And this looks like it's a question for Vahid. So Vahid, you use as your bioink gelatin methacrylate primarily. And what types of biomaterials other than GELMA would you consider using? What are the pros and cons of GELMA?
Yeah, that's a great question. Like Holly and I mentioned, most of our work is on GELMA-based bioinks. We are using GELMA as a base for most of our soft tissue printing, I would say, but we do have modification of even GELMA-based hydrogels for most of our works, depending on what the 3D bioprinting process requires. For example, extrusion-based bioprinting versus stereolithography bioprinting, they require different kind of rheology and properties and mechanical properties from the ink. And for that, we've been basically modifying our GELMA-based bioinks significantly with addition of different filaments, different basically fillers, cross-linkers, photoabsorbers, and other components that are added to the process. In addition to GELMA, we are working with other types of inks for different types of tissue printing. I would say it's like a tissue-specific basically process. For hard tissue printing, for example, for bone and cartilage, we're using commercially available bone bioinks. These are basically biomaterials that are kind of replicating the bone structure, composition, mechanical properties, even CT signal, and the CT imaging that you would get from those inks are quite similar to the bone structure. Hyperelastic bone is one of those bioinks that we heavily use in our lab. Cellink also has this new grade of bone bioinks that are available. For other application, we have been looking into using decellularized tissue as a bioink. It's rather finicky material to work with for bioprinting procedures. It's not as stable and as structurally coherent as GELMA. So there are a lot more issues and complications, technical issues that need to be addressed. But that's something that we're working as possibly as a supplement to our other hydrogel-based bioinks. But that's a biomaterial question to answer, and it's an ongoing effort in the lab.
Great. And then another question for Vahid regarding your iPSC-derived construct. What kind of differentiation media did you use for maturation? And then have you tried combining these cells with endothelial and smooth muscle cells?
Yeah, good questions. So coming from Stanford, and from Sean Wu lab, Cardiovascular Institute, traditionally we've been using Wnt inhibitor basically protocols for cardiomyocyte differentiation. B27 protocol in particular is basically what we've been using recently. And for co-culture experiments with other vascular cells in particular, that's basically one of our main lines of work right now. We constantly work with endothelial cells, not differentiated from iPS cells yet. We're just working with primary endothelial cells or cell lines. But smooth muscle cells and endothelial cells are the two types of vascular cells that we're constantly working in conjunction with cardiomyocytes. So, which brings a lot more complexity, to the manufacturing process and maintenance of those tissues, having different types of cells in a single construct. Spatially, there are complications how to maintain these cells in connection to each other and coexistence of these different types of cells, and keeping them functional is a whole another story. So it's an ongoing work, but like many other labs, we're trying to just improve our co-culture 3D experiments with these cells. Yeah.
Great. And next question maybe for both speakers. What is the printing resolution? And also, what is the desired printing resolution, particularly for congenital applications?
Holly?
So when we're talking about really from a resolution standpoint for the congenital heart disease, we're looking at vessels that are 2 millimeters in diameter. certainly we were able to achieve that. And when we're talking about a freestanding tube, as in the second generation interstitial model that I presented, those are around 2 to 2.5 millimeters. So they're quite small. The walls really do not allow very much thickness at all, particularly to try to perforate them. And so what we're looking for is about a 1 millimeter thickness around that vessel or less. We have been able to achieve that. The resolution is quite good in terms of having a reproducible vasculature. And right now we're primarily using Luminex to make those freestanding conduit type structures or freestanding tube-like structures that we can penetrate with wires.
Great. And then an interesting question, which is, how did the collaboration between you two initially begin?
Well, Vahid and I both originated from Stanford. So I did my fellowship training in interventional cardiology and also cardiology at Stanford. I knew of Vahid. And so when he came to Emory, I approached him and said that I thought it would be an excellent way for us to just start brainstorming about topics. It actually, I think Vahid can attest to this, went a little bit faster than what we thought it might. And so being able to, as a clinician, get free time to do basic science is challenging. And when that was accomplished, then you're able, to apply for funding mechanisms and things like that. When I received a K award, I think that solidified time that I could really dedicate. And I don't know, now it's a really fruitful collaboration. Having both people in the room at the same time, sometimes clinical things are brought up that need some modification and maneuvering, and vice versa. A clinical application that is brought up from a bioengineering standpoint, Vahid can definitely direct it in another way. I don't know if you want to add more to that, Vahid.
No, I think you nicely covered pretty much, all the advantages of having such collaboration. A lot of colleagues, at Emory, Georgia Tech, they are seeking these sorts of clinical synergies and collaboration. It's always tough to secure these clinical collaborators, considering they have always these distractions, being busy with clinics and unexpected schedules, especially for many of their works. But I think we were fortunate enough to be at the right place at the right time, and I think our understanding from each other's schedules and the nature of our jobs helped a lot the two sides to understand and define a working plan that so far has been working, I think, very well, and we're very excited about it. Yes.
Great. And now maybe we'll take two more questions in the interest of time. This one's for Holly. What would you take for your models to be adopted clinically? Does it require some kind of trial to demonstrate that improves outcome or not?
Well, interestingly, in congenital heart disease, we really don't have the luxury of having the same disease present itself over and over again. So the model that I just showed you for connecting the pulmonary vasculature for that particular patient is specific for that patient. So we would not necessarily be able to apply that same geometry, for example, or same diameter for every patient. So in some ways, we're kind of in a unique setting in the sense that if we prove that we can improve flows, that would be the technique for that particular patient that we would approach. For example, in coronary artery disease, you have thousands of patients that we can test, intimal proliferation or atherosclerotic plaque. But in peds, again, in congenital heart disease in particularly, we just don't see the numbers. So some of this is a true personalized case-by-case basis. So for the patient that I presented, the adolescent, if we can prove that a connection will work at a certain angle, I'll be honest with you, that's what we'll propose for that particular patient. It's a developing and unique arena to try to do some of this in pediatrics.
Great. And a last question for Vahid. This is regarding your GELMA. The question is, do you use temperature control for GELMA printing?
Yeah, that's one of our basically continuous struggles. As I mentioned during the talk, we right now have 4 different bioprinting systems, and each bioprinting machine has its own, tricks to get, an optimal work and printed structure out of it. And for most of our bioprinting systems, we do need temperature control, and we usually print slightly lower than room temperature, and that's usually the type of range of temperature that we need. we synthesize our own GELMA, which has been, extremely, I think, advantageous for our research progress, and not being dependent on commercially developed products, and being consistent with our quality and basically the scale of the GELMA that we produce. In terms of temperature control, we control the temperature of the nozzle, also the stage, most of the times, and these are usually just slightly lower than room temperature. But like I said, it changes based on the printing system, and even like the time during the day, during the year, during the month. Those basically every small changes in the environmental setting could significantly change your printing parameters.
Great. Well, thank you very much to all three speakers for such inspiring talks. And feel free to contact these speakers if you have follow-up questions. And with that, please also note some other upcoming SFB seminars, and I'll hand this over back to Dan.
Dan, thank you very much. Nico, Holly, Vahid, thank you all very much for your time today. It's really appreciated. We set a record for attendance for an SFB webinar yet again. So thank you, thank you, thank you. A couple of quick housekeeping announcements. Wanted to let you all know that we have postponed the Hawaii Symposium, scheduled originally for December of this year. It will now take place July 29 to 31 of 2021 in Honolulu. And we've also launched our call for ideas for the 2021 annual meeting. That's going to be in Chicago, April 21 to 24. And those ideas are due to be submitted by the end of June. So if you have any ideas for program content for next year's annual meeting, please submit them by the end of June. info@biomaterials.org. We're also working to reschedule our Sagan Young Scientist Socials, hopefully at the World Congress now in December. We're also just wrapping up a needs assessment survey. So if you've seen the SFB needs assessment survey that went out to all members, please send us some input there. We'd really appreciate what you want to see for additional member benefits as we move forward. And lastly, please be on the lookout. We're working to get our SFB members only annual business meeting scheduled. There's a bylaws amendment that needed to be executed before we could do that, and that bylaws amendment voting period ends today. We'll get notification of the annual business meeting scheduled next week, I'm hoping. So thank you all again very much for your time today, and please reach out if there's anything I can do for you.
Thank you.
Thank you all.
Thank you.
Bye.
Thank you, Nico. Have a great day.
Have a great day too. Nice weekend.